Hello, I'm Dr. Rebecca Brown, and on behalf of Creative Educational Concepts, I would like to welcome you to today's educational activity entitled the MEKtrix, Advancing Neurofibromatosis Type 1 Across the Lifespan. Today's program is supported through an independent educational grant from SpringWorks Therapeutics, Incorporated. Today's program is brought to you by Creative Educational Concepts, an award-winning accredited provider of continuing education for clinicians worldwide. These are the different types of activity credits that you can apply for at the end of the program. Please take a moment to make sure that you understand. Today's activity will include discussions of products or devices that are not currently labeled for use by the US FDA. We will point these out. I'd like to introduce myself. I'm Rebecca Brown, MD, PhD. I'm director of the NF and schwannomatosis program at the University of Alabama at Birmingham, and I'm an associate professor of neuro-oncology. Dr. Chow?
My name is Dr. Lionel Chow. I'm an associate professor at Dayton Children's Hospital and affiliated with Wright State University in the Boonshoft School of Medicine.
Dr. Yohei?
My name is Caleb Yohei. I'm a pediatric neurologist at NYU in New York City, where I run the comprehensive NF Center and I'm the director of child neurology.
Thank you. These are our learning objectives. Our learning objectives, these are disclosures. These are our learning objectives. Our learning objectives begin with to assess the neuro-oncologic features of neurofibromatosis type 1, including tumor types and neurologic signs, to support early recognition and guide clinical decision-making. Additionally, to evaluate the use of MEK inhibition in the management of neurofibromatosis type 1-associated plexiform neurofibromas in pediatric patients, including team-based care to manage adverse events. And then finally, to develop evidence-based interprofessional care plans for patients with neurofibromatosis type 1 that reflect current clinical standards and support individualized longitudinal management. I'd like to briefly go through how to submit a question. During this program, you will be able to send in questions via the Ask a Question tab on your iPads. We will try to take questions as they come in if we can. Otherwise, we'll try to get to them closer to the end of the program. On another note, there will be times during the program that we'll take a break. This is not going to be one long epic marathon where you sit and we talk. So there will be times that we'll take a break and take questions throughout this discussion. And if you have an idea for a discussion topic that's not specifically a question, feel free to submit that as well. I'll keep an eye on it here on the iPad. So let me start by going over NF1 clinical features and diagnostic criteria. The neurofibromatosis are divided into grouping, which includes NF1 and schwannomatosis. And within the umbrella of schwannomatosis, we have NF2-related schwannomatosis and non-NF2-related schwannomatosis. Those are not the focus of the discussion today, but I did want to point out that NF2 is now considered to be part of that other separate umbrella group. Those conditions are less common. NF1 is estimated to occur in about 1 in 2,500 to 1 in 3,000 individuals worldwide. And this includes all ethnicities and both sexes affected equally. And additionally, there is a 50% risk of the patient being the proband, the first individual in their family who's diagnosed, and additionally 50% of the people who have NF1 have inherited the condition from a known affected primary relative, being a parent. NF1 affects every tissue in the body. So the root causes of the symptoms of NF1 are related both to a haploinsufficiency of the NF1 protein within all tissues of the body, and then additionally the tumors and some other features are caused by loss of the second NF1 allele and then the accumulation of additional mutations. But this does affect all aspects of an individual and can lead to tumors that include not only cutaneous and plexiform neurofibromas, but brain tumors such as gliomas, tumors of the GI tract such as GISTs, Patients can have juvenile xanthogranulomas and childhood leukemias. There can be cardiovascular alterations, and of course, alterations of the skeletal system that can be both deformative and cause chronic pain, and also lead to a need for multiple surgeries to repair bony abnormalities throughout the lifetime. So these patients definitely merit being followed by an expert in NF and or a multidisciplinary group. The timing and severity of the different features of NF1, of course, varies across different individuals, but we believe pathoetiologically and through the ontologic development of the neural crest population of stem cells that cafe au lait macules, the orbital dysplasia that we see in the bones of the skull, tibia dysplasias, pseudoarthrosis, and plexiform neurofibromas are initiated relatively early during development. Learning deficits, ADHD, autism spectrum disorders, motor and or speech delays, and optic pathway gliomas usually present between infancy and early childhood, although not always. And the skin fold freckling, leash nodules, scoliosis, dermal neurofibromas, paraspinal neurofibromas, and brainstem gliomas, we oftentimes diagnose these between early childhood and adolescence. The paraspinal neurofibromas sometimes become active more towards adulthood, and gliomas can be also detected more in adulthood. There's a range, but this is an approximate estimation. And malignant peripheral nerve sheath tumors, they can happen in childhood and adolescence, but they're most common in the 20 to 30-year-old range of adults with NF1. Breast cancer is most common in young adults with NF1 in their 20s and in their 30s, which is why we recommend screening for breast cancer beginning at 30 years old in adult women with NF1. And high-grade gliomas, including glioblastomas, are most common in the adult population. Why don't I pass it on to Dr. Yohei now to take over and talk more about the clinical symptoms of NF1?
We're going to talk just briefly about some of the clinical features of NF, because I'm sure most of you are familiar with these symptoms. So cafe au lait spots, obviously one of the most prominent features of neurofibromatosis. It's listed here that 90% of patients with NF1 have cafe au lait spots. The reality is it's probably higher than that. There are a number of studies. It's anywhere between 90 and 98% of people with NF1 will have cafe au lait spots. It's unusual but possible to have NF1 without cafe au lait spots, often in the setting of mosaicism. Cafe au lait spots are typically the first thing that we see. Babies can be born with them. They can acquire them during the first months or year of life. And then can continue to accrue more through childhood and sometimes begin to fade in adulthood. One of the things that we often talk to families about is the fact that these are not a marker of severity. So whether or not you have 6 cafe au lait spots or 60, it does not indicate that you have a more severe form of NF1. And the accrual of new cafe au lait spots doesn't tell you that the disease is progressing or changing. I will say, though, that there is a correlation between the number of cafe au lait spots and the likelihood of having NF1. So if you have a 1-year-old that has 6 cafe au lait spots and one that has 20 cafe au lait spots, if both of those children have sort of typical ovoid hyperpigmented macules, the one with the higher number is more likely to end up having NF1. Skin fold freckling we typically see start to develop in post-toddler, early school age. We call them freckles, though in many ways they aren't sort of the typical freckle that you see in kids that don't have NF. They're, if you look at your own freckles, they tend to be very round. These are more confetti-shaped lesions. They're really scattered, tiny cafe au lait spots, and they often cluster around the armpits and the groin area, skin folds around the neck, sometimes on the chin, below the lower lip. And these are, in terms of cosmetic distress, they don't typically cause as much distress as cutaneous neurofibromas or even the cafe au lait spots, but for some patients, they do become quite prominent and can be something that they wish they didn't have. But All kids with NF need to be seen regularly by ophthalmology, primarily to evaluate for the presence of signs that might indicate the presence of an optic pathway glioma. But additionally, it can be helpful with diagnosis for kids that don't have clear or haven't met diagnostic criteria otherwise. Lish nodules, we're all familiar with, were part of the original diagnostic criteria. And through the lifespan, most people with NF will develop Lish nodules. It's not universal, but they often don't show up until later in childhood. So they're not always helpful up front with the first eye exams that we're getting in kids when they're at that age when we're worried about optic pathway glioma. In the new guidelines, the new diagnostic criteria, which we'll come back to in a minute, choroidal abnormalities are now part of the diagnostic criteria. The reason these were added is that they do show up earlier. They are more sensitive and more specific for a diagnosis of NF1. Unfortunately, they do need to be, a child needs to be examined by an ophthalmologist who knows to look for these in order for them to be identified. Neither Lish nodules nor choroidal abnormalities really have any clinical importance. They don't impact vision. They don't impact function. They're not really cosmetically an issue. So they're just there to help us make a diagnosis. Again, just very briefly, other manifestations that we see in NF1, cutaneous neurofibromas or dermal neurofibromas are small, benign tumors that occur within the dermis and on the surface of the skin. There's a wide range of severity for cutaneous neurofibromas. There are some patients with NF1 that never develop them at all, but that is rare. And there are some patients that are covered head to toe in these, which is also rare. Most patients are somewhere in between where they have a significant number, enough that they, again, wish they didn't have them or are distressed in some way or shape or form. But it does vary in terms of how much impact cutaneous neurofibromas have on a given individual's self-esteem, interaction socially, and in many ways, all aspects of life. Cutaneous neurofibromas can be itchy, they can be painful, but often are neither, and they do not become malignant. So we don't have to worry about them turning into a malignant tumor. However, they can sometimes mask the presence of a basal cell carcinoma or a melanoma, just because physically they may obstruct sort of our visualization of those other types of tumors. We do see bone abnormalities in people with NF1. Listed here are tibial dysplasia, which can result in pathologic fracture and pseudoarthrosis, which can be a very problematic feature of NF, typically shows up before age 2, and can require multiple surgical procedures to correct. Sphenoid wing dysplasia can also be associated with NF1, sometimes associated with an orbital plexiform neurofibroma, but sometimes occurring in the absence of a neurofibroma. Unclear what the relationship is between sphenoid wing dysplasia and the presence of a plexiform neurofibroma is. One theory is that there are congenital plexiform neurofibromas that develop around the same time that the orbit is developing and impact bone development, but then some of them regress, leaving the bone abnormality as a sort of a sign that the plexiform was there. Not listed here, scoliosis is also a big issue in kids with NF1. We see dystrophic scoliosis, where we see abnormalities of the vertebral bodies as well as the ribs. We can see dural ectasia, meningoceles, also associated with scoliosis. Similar to the sphenoid wing dysplasia, sometimes scoliosis is associated with a specific tumor adjacent to the spine, and sometimes you get the same sharp angulated scoliosis with no plexiform neurofibroma, and it's not clear what the association is there as well. Plexiform neurofibromas we're going to talk about separately, but they're one of the more complicated aspects of NF in terms of management, and again, we'll talk more about that later. And then, of course, optic pathway gliomas, which we see in about 15% of kids with NF1, can impact vision. About a third of that 15% will have functional impairment as a result of an optic pathway glioma, and it's only that 1/3 that we typically treat. And treatment these days can be either traditional chemotherapy or MEK inhibitors, but we're not going to talk too much about optic gliomas today. A few years ago, there was an effort, a multinational, many subspecialty, large Herculean effort to update the diagnostic criteria. The original diagnostic criteria were published in 1988 before the NF1 gene was even identified. That being said, the 1988 criteria were actually pretty good. It's pretty sensitive, pretty specific, and really captures most patients with NF1. So the update didn't have to change too much, but a few key things that I just want to highlight. Probably the most important is that genetic testing is now considered a diagnostic criteria. This was added in large part to help with getting coverage for insurance to pay for genetic testing, because previously, without having genetic testing part of the diagnostic criteria, health insurance companies could argue that it was not necessary nor even part of the diagnosis, and so they wouldn't cover it. A pathogenic variant is now considered to be one feature. It is not sufficient to make a diagnosis of NF1. You need to have an additional clinical feature as well. The other key changes were the addition of choroidal abnormalities, as I mentioned before, which allows earlier diagnosis in kids and is also more specific. There were some updates in some of the wording around the bony abnormalities, just to clarify, particularly around the tibial bowing and cortical changes that we see in the bone. And then lastly, the family history genetic contribution was changed a little bit. It must be a parent that meets the diagnostic criteria as opposed to a sibling. I will also say that, not included here, but one of the asterisks in the new diagnostic criteria is that you need to have two diagnostic criteria to meet the diagnosis of, to make a diagnosis of NF1. But if those two criteria are cafe au lait spots and axillary freckling, while that is likely to be NF1, you can't exclude Legius syndrome, which is a mutation in SPRED1. So, and those, frankly, are the two most common early manifestations of NF1, so often we are relying on the presence of cafe au lait spots and freckling, but you just have to keep in mind that you can't exclude Legius at that point. Because NF1 affects so many different body systems and in so many different ways and at so many different times, this is a team effort taking care of patients with NF1, as many of you here know. That team includes diagnosticians and diagnostic technology such as radiology, genetics, other ways of looking at neurofibromas. From the sort of care standpoint, there's an involvement of neurologists, geneticists, neurosurgeons, plastic surgeons, orthopedic surgeons, advanced practice providers, a whole variety of different care subspecialties, all of which have to be brought to bear in one way or another on the care of these patients. And that can be done in a number of different ways, but varying from sort of multidisciplinary clinics where you have multiple medical providers seeing patients at the same time, or sort of virtual networks of providers. We've also found sort of supportive therapeutics to be a really big part of our multidisciplinary care, so OT, PT, rehab, vocational rehab, neuropsychology, social work, et cetera. Because frankly, those are the services that everybody with NF is going to need at some point. Not everyone is going to need an orthopedic surgeon, but almost everyone is going to need a physical therapist, or an occupational therapist, or a neuropsych evaluation at some point. And then finally, the most important piece of the whole puzzle is engaging patients and families in guiding care and in this sort of larger coordinated team approach. So with that, we're going to move to a brief video. This is Renee Moss, who is well known to many people in the NF world. She is a mom of a child with NF1 and has been a tremendous advocate for parents and families with neurofibromatosis.
Let's move forward one more slide.
The challenges of accessing a neurofibromatosis clinic or a clinic that is well-versed and experienced in neurofibromatosis care, access to specialists that may be needed in that continuum of care is very, very hard in our country, in the United States specifically. We were very fortunate when we received our diagnosis. 5 minutes away was one of the best NF clinics in the country. So it was not our experience, but in my 10, 11 years of managing this with my family and engaging with parents and patients in the NF community, our experience is very unique. Most families do have to travel at least some distance, sometimes a long distance, to access the care they need. That can affect your job. That can affect your employment. That can affect your school. That can affect your pocketbook, your finances. And, we're also a middle income family with insurance. Not everybody has that ability. So if you need an MRI and you're 4 hours away, having the ability to do that, but then having to go back to get the results of that, or having to come do, blood work or a scoliosis scan or a DEXA scan, if those appointments can't be coordinated, that's a very expensive both time and financial commitment for that patient or that family to be able to travel back and forth and do that. And with NF1, because there are so many learning disabilities and sometimes multi-generational diagnoses, the ability to maintain successful employment is sometimes a challenge. So you add the distance and the financial toll it takes on a family to be able to access that care, along with the ability to maintain employment, to be able to do that. It is a huge, huge stressor and frustration.
So Renee's family was diagnosed with NF1 at a relatively late stage. Her children were not diagnosed at birth nor in childhood, but in their adolescent years. And they had somewhat of an atypical presentation, which is why the diagnosis came so long. Her son had a swelling on his neck that was felt to be post-viral syndrome and ultimately was biopsied and found to be a plexiform neurofibroma. Because that was such an atypical case, we have here a more typical presentation, and we're going to use this case, but also Renee's case. By all means, please feel free to submit questions or conversation points that you'd like us to cover regarding both. This case is a child that we're going to call Mark. Mark S. is a 6-year-old boy referred for evaluation of mild developmental delays and behavioral concerns. These are very common with NF1, as we all know. He did have delayed expressive language, and he has been struggling in school. His kindergarten teacher and parents reported signs of possible ADHD, as well as some social anxiety. He was noted on his presentation to have behavioral issues. He very clearly had a poor attention span in the clinic. He did have some emotional outbursts, and he exhibited difficulty with fine motor tasks. His teachers had noted impaired interactions with his peers. He was not found to have any visual difficulties by his parents or his teachers, although he was not yet formally assessed. His mother at the clinic appointment was noted to have some cafe au lait spots, and she had some very obvious scoliosis, but there was no confirmed NF1 diagnosis in the family, and there was no family history of cancers or seizures. On exam, he himself was noted to have 9 cafe au lait spots. And of course, importantly, these spots were over 0.5 centimeters in maximum diameter, because it's not just part of the criteria that they have cafe au lait macules, but that they meet certain size criteria, which are different for the prepubertal and postpubertal children. He did have bilateral axillary freckling. He was not noted to have any cutaneous neurofibromas and none that were palpable through the skin. The flashlight was held up against his irises in the clinic, and no leash nodules were visible. But again, I would point out that technically for criterion meeting leash nodules, they have to have a three-dimensional structure, not just pigmentary changes along the iris. And so a formal slit lamp exam with an ophthalmologist or a trained optometrist would be necessary for a definitive diagnosis of leash nodules. He was mildly hypotonic. He had some difficulty with coordination. And when he was bent over, there was some mild scoliosis that was palpated along his spine. He had no long bone abnormalities. He did have some visual, spatial, and processing deficits and some attention and executive function concerns. So at this point, we're going to have everybody weigh in as to which approaches you would recommend for this patient. There should be a questionnaire that pulls up on your iPad. If there's not, please raise your hands and we'll work with the team to make sure that that appears to you. Excellent. Thank you. As always, it makes these events much more informative when we can interact during the event, and I can see your responses. So about a third of people recommended genetic evaluation. 8% recommended neuropsychological testing. Nobody seemed interested in occupational therapy. Ophthalmology was recommended. That's good for leash nodules and to check vision. Speech-language pathology testing is always a good option. And 6% recommended magnetic resonance imaging of the brain or orbits. A referral to comprehensive NF1 clinic was recommended about 1/5 of the time. So I'd like to start a little bit of a discussion here. There were some recommendations that I think that our pediatric neuro-oncology experts could weigh in on. Dr. Yohei and Dr. Chow, how would you like to comment on the referrals, 8% referrals to neuropsychological testing? Let's start with Dr. Yohei.
Well, my first question was, is this a forced choice? I don't know how it was presented to you guys. So, I mean, there are many, many of these things that I think we would want to do. So I don't know if people just pick their favorite of them.
Very good point.
But yeah, I mean, around this age, he's 6, I think. 6 is a very common age for a neuropsych referral. We will often see, some of the more subtle learning disabilities, executive function deficits, ADHD will become most obvious as kids are getting their first sort of academic stresses in kindergarten and first grade. And so that is a very typical and helpful time to proceed with neuropsych testing.
And Dr. Yohei, let's say that this patient was found to meet criteria for ADHD at his age, and let me remind myself, 6.
Yeah.
Would you proceed with recommending that this patient follow with a child psychiatrist and consider medication at this age? Is there a difference between these patients and patients who do not have NF1 as far as your recommendations go?
I only see people with NF, so I don't know about other kids. Yeah, so I mean, this actually is very regional specific, like who's managing ADHD. And so in some regions, pediatricians manage ADHD, and some psychiatrists do, and then some neurologists do. And in our clinic, we have taken the practice that we discuss and offer ADHD treatment to patients that are interested. Not everyone is interested. Often we'll make recommendations for environmental changes, school changes, prior to considering medical therapy. But medical therapy ends up being used in a pretty significant portion of our patients. Probably about a third will go on a stimulant medication at some point.
So as with much of NF1, it's very individualized.
And sorry, I'll just comment that, obviously this case is heading towards a diagnosis of NF1, and that's what we're going to discuss here. But with this presentation, even if the patient did not have NF1, it might even be, appropriate to refer for neuropsych testing just because of the presentation and the discuss school difficulties.
Of course. Dr. Chow, I was going to come to you next with 36% of respondents would move next to genetic evaluation. How important is genetic evaluation in a child who meets clinical criteria for NF1?
Yeah, I think there's a variety of ways to answer that. I think for this particular case, I think genetic evaluation is appropriate because, as we spoke earlier, strictly speaking, he did not meet the criteria, the clinical criteria to make a diagnosis, and he could fit into the category of patients with Legius syndrome. Mm-hmm. So genetic evaluation in this case could definitively make that diagnosis. But even if a patient did meet the criteria for clinical diagnosis, I think genetic evaluation is very helpful in these patients because oftentimes, families want to know if, as you spoke about earlier, if this is a case, a spontaneous case in the family, or if this is a case with a family history, and genetic evaluation can help with that because once you have the identified mutation, then it's much easier to look for that mutation within the family structure.
And a great segue again would be that the mother also showed some very obvious signs that could be associated with NF1. Would you refer both the mother and the child to genetic testing, or start with the child?
I would. That's a great question. I think I would probably start with the child as the proband, and I think people in this audience might be familiar, depending on which method you choose to get your genetic testing once you have the identified mutation. Oftentimes family testing is then free for other family members. There are some companies that offer that, and I think your facility might even offer that as well. So I would probably start with the child first, but I think it would. I don't think that's like 100%. The mother also did have some symptoms, so it might be appropriate to start with her. Mm-hmm.
I would actually start with a physical exam of the mom first, and if she meets clinical criteria at that point, the child then meets clinical criteria. You don't necessarily need genetic testing. There's very poor genotype-phenotype correlation with in NF1, with very few instances where the specific mutation correlates with a specific outcome. So if you have clear diagnostic criteria that are met, it really becomes optional whether or not you do genetic testing.
And one final question for you, Dr. Yohei. The referral to ophthalmology, would you refer to optometry ever? I know in some regions of the United States, again, patients have to drive many hours to find an ophthalmologist, but an optometrist might be right around the corner. If the family is saying, look, it's beyond our means to drive 4 hours just to see an ophthalmologist, how would you deal with that situation? Would you encourage them to do so, or would you work with an optometrist?
In my adult population, I will say an optometrist is okay, but in my pediatric population, I would not. I really will work with families to make sure that they are seen by a pediatric ophthalmologist, and preferably one who's actually quite familiar with NF. And so we will often try to coordinate visits so that when they're coming to the NF center, that they're seen by a child ophthalmologist.
And to clarify, the choroidal abnormalities that are seen with NF1, would those be visualized on a dilated eye exam, or do we not know?
You need, you need near infrared visualization or OCT. So that's not something that a typical optometrist would be able to do.
So very important for diagnostic purposes for the child to see an ophthalmologist. I don't have any questions or suggestions yet. My feelings are hurt. Please send me something. But at this point, we're going to move on.
Especially the NFologists in the corner over there. They should.
Called out. Okay, so according to this case, our team would recommend follow-up comprehensive ophthalmologic exam with optical coherence tomography. This does reveal choroid nodules, and this does confirm a diagnosis of NF1. At this point, our recommendations were to perform formal analysis of the curvature of the spine, as well as, of course, a baseline neurologic evaluation and developmental monitoring, referral for developmental behavioral pediatrics for ADHD and behavioral support. We did refer the child and his parent to genetic counseling to discuss inheritance pattern, additional family testing, and reproductive planning. Reproductive planning is very important. We could talk later if anybody wants to I'll encourage you to put this question in the chat if you want to talk about when and how to talk about reproductive planning with NF patients. That would be something we could cover later. And ongoing occupational therapy and speech therapy. Therapy is always welcome to help a child, again, in addition to or as an alternative to medication. The parents were hooked up with the Children's Tumor Foundation. So the Children's Tumor Foundation does not just take care of children and does not take care of all children's tumors, but they do take care of everybody with NF. And this is how I explain it to my adult patients and my families is don't be put off by the name. Definitely go to the Children's Tumor Foundation website. That they have some great infographics and brochures and information, and it's a wonderful community that they can do their research and learn on their own. And then follow-up appointments for NF1 surveillance that were recommended included an annual neuro exam, dermatologic exam, especially as these children move up into late childhood or early adolescence. They may be shy about it, but they may have some insecurity issues regarding developing skin lesions or plexiform neurofibromas involving their skin, and then also to track their growth and development. Dr. Yohei, how often would you recommend an ophthalmologic check-in?
Our practice currently is basically to do ophthalmologic evaluation every 6 months until kids are able to really cooperate with the examiner well enough to get a really good exam, at which point we go to once a year. And we do once a year throughout childhood. And then at what point we can either stop or sort of spread that out is not totally clear in the guidelines. So I tend to continue to do annual exams until kids are, headed off to college and then go to every other year.
Very helpful, thank you. There are some missed opportunities that can occur in a clinical management of a patient with NF1. Failure to recognize diagnostic criteria is one of those. A lot of times these children present with obvious cutaneous findings, and then a further workup determines their additional criteria for meeting a diagnosis of NF1. Missing those additional criteria can be a missed opportunity. Underestimating the impact of mild developmental delays, and this is true for any child, and I think that everybody in this room will be attuned to the developmental delays that can be presented amongst any children who present at the clinic. Delayed referral to specialists, Dr. Yohei did emphasize the importance of referring to ophthalmology in this particular situation. Inadequate family history taking, it does help when the parent is there, and you can ask the parent about other affected individuals. Any lack of coordination with schools is always difficult. Overlooking any emotional or behavioral health, approximately up to 85% of adult individuals with NF do suffer from some form of a mood disorder or neurocognitive deficit. Early diagnosis can help prevent or delay complications of NF1, and one of those would be development of dystrophic scoliosis, and not referring to NF1 specialty clinics. With regards to the scoliosis, Dr. Chow, how would you quantify scoliosis, or what tests can be ordered, and when would you act on scoliosis being severe?
Yeah, I think that your initial screening test would be like the scoliosis spine series, which can quantify the degree of curvature. But as was pointed out, sometimes scoliosis can be associated with either spinal neurofibromas or plexiform neurofibromas. So it might not be unreasonable if there was a suspicion for those being present to obtain an MRI scan to look for those, because they will not be seen on the spine, just a plain X-ray of the spine, of course.
What angle of scoliosis would raise your concern?
Yeah, well, this is more of an orthopedic surgery question, but my understanding is that bracing can be done, and obviously there are certain time periods in the child's development when it's more important to be intervening in their scoliosis because of rapid growth periods and throughout childhood, of course. So bracing would be an initial intervention, but a more intensive surgical intervention, I think, would not be recommended until you get to about 40% curvature.
Very helpful. And you mentioned that you might consider MRI of the spine if you determine the child had some severe scoliosis. Dr. Yohei, you had mentioned earlier we were talking about optic pathway gliomas, and some of the members of our audience here had voted to go ahead and pursue an MRI of the brain at that point. What would trigger you to recommend MRI of the brain for a patient of yours for concern for optic pathway glioma?
Can I answer the scoliosis question first?
Absolutely.
Okay. Just a couple things about that. One is we try to avoid radiation in kids with NF. One thing that we've really moved to doing is something called the EOS, which is a very low dose radiation full body X-ray, which will also tell you about leg length discrepancy, hip tilt, as well as curvature. And leg length discrepancy and hip tilt are things that we often see associated with NF as well, sometimes with limb overgrowth because of plexural neurofibroma, and sometimes separate from that. The other thing I would say is that based on the X-ray and the examination, it can help guide you as to whether or not MRI is needed, also can help guide you in terms of bracing. If the angle is a short, only over a few vertebral bodies and it's an acute angle, bracing is probably not going to be helpful at all. So that category of dystrophic scoliosis really doesn't respond to the typical treatments and preventive measures that we take for idiopathic scoliosis. In general, we start referring kids to orthopedics when we're at like even less than 20 degrees, because sometimes even at that stage, surgeons will go ahead at that point. And then optic pathway glioma and brain imaging.
And I'm seeing that thank you, friends. There are a couple of questions now. One of them was, what is the reason for very frequent ophthalmologic exams early on, since the NF lesions do not affect vision?
Well, that leads right into the optic pathway glioma discussion. So really the main reason, I'm sending kids to ophthalmology, not for the diagnosis typically, because usually we have a diagnosis from other reasons, to be honest. It's rare that the diagnosis falls squarely on the presence or absence of Lisch nodules or choroidal nodules. It happens, but not that often. So really what we're doing is we're screening for the development of optic pathway gliomas. So kids between age 2 and 5 are at the highest risk of development of these benign tumors of the optic nerve, which can occur anywhere along the optic pathway from just behind the globe to the optic chiasm and even into the optic radiations. As I mentioned before, about 15% of kids will have an optic pathway glioma. Of that 15%, only a third will ever become symptomatic. We treat those that are symptomatic. We don't treat the ones that are not. So radiographic evidence of an optic pathway glioma doesn't necessarily mean that you're going to go towards treatment, which then sort of informs our decision about whether or not to get imaging. I think this is a bit of a controversial topic. In some places, some institutions, some clinics will do a baseline brain and orbits MRI on every child. The current guidelines as they stand right now are that we only do baseline imaging, or we only do brain imaging if there is some concern based on history, physical exam, or ophthalmologic exam that there might be an optic pathway glioma that's causing functional impairment. Again, because we're not going to treat a kid, if they have an optic pathway glioma and no functional impact of that tumor, we're not going to treat it. So it doesn't change what we do for that child. So at our clinic, we do our best not to do imaging. One of the main reasons for that is because of the nature of NF and what we tend to see on imaging, there's a very high likelihood that if you do an MRI on a 2-year-old, for instance, and you sedate them for that one MRI just to sort of see what's going on, you may be committing that child to 20 or more sedated MRIs over the course of their childhood. And each individual sedation probably doesn't have that much impact, but when you start getting into repeated anesthesia events over the course of a child's life, you accrue not only sort of just risk for pneumonia and things like that, but also for cognitive development as well. So I'm personally am very hesitant about doing baseline MRIs.
And can you remind us the percentage of children who have a known optic pathway glioma and that glioma spontaneously regresses?
I don't know that we have that number. We don't, but it definitely happens. I think we used to be much more aggressive historically with treating kids with optic pathway glioma, and I think we got a lot of credit for tumors that would have gone away by themselves. But I don't know that we know. Do you guys know the number? Yeah, no. Thank you for saying no.
All right. Let's move on, and I believe we'll hear from Renee Moss again. This is not advancing. There we go.
For us, ours was rather unique, but as I've over the years found out it's not that unique. Our son was not diagnosed until he was 6 because he does not have the usual capiolae spots. He doesn't have freckling in the groin or armpits. He does not have Lish nodules that would have been picked up in an eye appointment. He does not have learning disabilities. Some of the things that would be kind of the main dominant issues that would arrive with NF diagnosis. His diagnosis came because he had a tumor in his neck that we thought was a lymph node, which fast forward a year is how long it took for them to realize it wasn't a lymph node and it was in fact a plexiform tumor. Then a year later, our daughter was diagnosed through genetic cascade testing, and with an autosomal dominant genetic condition, that meant mom or dad had to have it. And so at age 36, my husband was diagnosed with NF1. So we have 3 different presentations or phenotypes of NF1, same genetic variant.
So Renee brings up plexiform neurofibromas, which is one of the major topics that we wanted to cover today. I'm going to hand the pointer back to Dr. Yohei to talk to us about MEK inhibitors.
I'm not going to talk too much about MEK inhibitors, but I'll talk about tumors. And then we'll turn it over to Dr. Chow for MEK inhibitors. But, NF1 is a tumor predisposition syndrome, and we've talked about several of the different tumor types in NF. It is also a cancer predisposition syndrome, and I like to make a distinction between those 2 different things, especially when talking to families, because they may not understand that the word tumor doesn't necessarily indicate cancer. In talking to families, it's often really important to clarify that, especially for kids as they're starting to learn about their condition, to let them know that they may hear the word tumor, but that does not mean that they have cancer. But that being said, this is a disruption in the RAS pathway. Patients with NF1 are at increased risk for several different types of tumors.
Adjust the slide. There we go.
Sorry. We talked about dermal cutaneous neurofibromas. The current correct terminology is cutaneous neurofibroma. Just that's been agreed on more broadly. Plexiform neurofibromas, which we'll talk more about in a bit. We've already talked about optic pathway gliomas. Kids with NF can also get other brain tumors. Low-grade astrocytomas are the most common and don't always have to be associated with the optic pathway. So tectal, brainstem regions are often affected. You can get supratentorial low-grade gliomas as well. MPNST is one of the most devastating complications of neurofibromatosis type 1, with a lifetime incidence of probably anywhere between 10 and 15%. These are very high-grade, progressive sarcomas with very poor survival and outcome. High-grade gliomas, just to jump back to the brain, we see that in kids not too frequently, but it does happen. And we can see it in adults with NF1 as well. Breast cancer risk, it's really only in the last decade or so that we've recognized the rates of the increased risk of breast cancer in women with NF1. Women in their 30s and 40s probably have as high as a 14-fold risk compared to the general population. Overall, lifetime risk of breast cancer in NF1 is about 4-fold compared to the general population. The current NCCN guidelines are to start breast cancer screening with mammogram annually and breast MRI when able, starting at age 30. And I mention that to this crowd only because that should be part of your discussion with teens and kids who are transitioning into adult care, so that they're aware that that's something that they need to be thinking about ahead of time. Other tumor types that we see, gastrointestinal stromal tumors, which are GI tumors. We see in a few percent of people, adults primarily with NF1. Pheochromocytoma we can see, again, mostly in adults. And then other sarcomas like rhabdomyosarcomas we can rarely see, primarily in kids with NF1. We really don't see elevated risk of other sort of major cancer types, so prostate cancer, lung cancer, colon cancer, we don't really think of as being elevated in risk. Melanoma, it's a little bit controversial whether or not there's an increased risk of melanoma. So really the things that we're changing our practice around are things like MPNSTs and breast cancer primarily from a cancer standpoint. All right, to move on to plexiform neurofibromas. So plexiform neurofibromas are these very complicated tumors that we see in about half of people with NF1. We don't really know the actual incidence yet. We would need to do whole body MRIs on everybody with NF at multiple ages to answer exactly how many people have plexiform neurofibromas, but right now our best estimate is 40 to 50% of people with NF1 have plexiform neurofibromas. These are thought to be congenital tumors present at birth, but they may not be visible or apparent or symptomatic that early, so it may seem like they develop later, but it's just because they're becoming apparent later. From a population standpoint, the period of most rapid growth is in young kids, but these really have a mind of their own and they can choose to grow whenever they like. Some will grow steadily throughout childhood and into adulthood. Some will take a pause and then start again later on. Some will shrink a little bit. They really can do almost anything, which means that they always keep you on your toes. These tumors are, Vic Riccardi is one of the greats of neurofibromatosis history, but he really described NF-related tumors as being not just like your regular old tumor. They're a combination of both inflammatory response, scarification, and overgrowth like a typical tumor. So plexiform neurofibromas are really a combination of overgrowth of Schwann cells, but there's also this invasion of haploinsufficient mast cells, fibroblasts, and endothelial cells, which are a necessary component of the tumor. And the relationship between the tumor microenvironment and these other cells, these haploinsufficient cells, and the hyperproliferative Schwann cells is not totally understood. These tumors are very problematic in that they grow along long lengths of nerves. They coalesce multiple nerves. They often grow in the plexus regions, but they can really appear anywhere in the body. They can be infiltrative in terms of adjacent tissues, muscle. They can compress bone. They can compress or impact organs. They sometimes invade the wall or are the wall of things like the bladder or the uterus, or sometimes you'll see them wrapped around hepatic vessels. So they really can look like almost anything and can appear almost anywhere. They can be life-threatening. They can cause impact on the airway. They can cause visual impairment if the tumor covers an eye. They can cause bladder or bowel dysfunction, both directly or because of impact on the spinal cord. And symptomatically speaking, they can cause pain, disfigurement, motor dysfunction. Most people have more than one plexiform-associated morbidity. We've already talked about the most common ones, pain, disfigurement, and motor dysfunction, as well as some of the organ impact it can have. Over time, these tumors tend to get worse, and the cosmetic appearance can change and can get worse. The skin gets thicker, more discolored. There's drooping of the skin. So even if the tumor is not enlarging, you can get progressive disfigurement. You can get progressive neurologic dysfunction, and pain often gets worse over time as well. Symptomatic plexiform neurofibromas tend to be larger than asymptomatic plexies. We do see small, we can even see large plexiform neurofibromas that are completely asymptomatic, and that factors into decisions around treating. Plexiform neurofibromas are benign, but as I mentioned before, there's a fairly high incidence of transformation to malignancy, MPNST. I will say the red flag symptoms that we pay attention to for plexiform neurofibromas when we're thinking about MPNST growth include rapid growth of like one portion of the tumor, so like a hard nodule developing in a previously soft homogeneous tumor, significant pain that keeps people up at night or wakes them up out of sleep or prevents engagement in activities, and new neurologic dysfunction. And then, sorry, I need my glasses for your note. Got it. So I'm going to jump ahead a couple slides, but basically, in deciding about treating plexiform neurofibromas, we factor in whether or not a plexiform neurofibroma is symptomatic or not, and whether or not it's surgically accessible or not, and how significant the symptoms are to the patient. So our idea of what may be significant may not be the same as the patient's idea, and so factoring that into our treatment choices is very important. Historically, we really only had surgery as an option, but of course with MEK inhibitors, we now have medications that are available that can reduce the size of plexiform neurofibromas. And so the conversation that we've had with our patients has totally changed over the last couple of years because there are other options besides surgery. So when we're weighing whether to treat a plexiform neurofibroma or not, we want to, on the pro side, if it's symptomatic, we may be able to reduce symptoms. If there's been recent growth, that may prompt us towards treatment. If there's significant pain, functional impairment, if tumors are in high-risk locations, and if kids are young and earlier in the disease course, that may also factor into treatment. There are downsides to medical therapy, including skin toxicities, other toxicities. We don't really know what the optimal duration of treatment is when we're making these decisions, and sort of talking to families about how long they might be on medication is a challenging conversation because we don't know the answer. There may be long-term sequelae to being on medical therapy that we aren't aware of yet, and long-term data is not readily available. So with that, I'm going to turn that back over to you.
Before I get back to the case, there are a couple of questions regarding what you just said, and I'm sensitive to time and all of y'all's time in this conference, so let's answer these questions with speed so we can get on to Dr. Chow. But Dr. Yuhei, would you recommend whole body MRI? If so, at what age? And a similar question would be, when would you do imaging for plexiform lesions in deep structures or viscera?
Okay, so the whole body question I'll answer first. I feel like we're in a bit of a transition period here. Whole body MRI isn't necessarily widely available and isn't always paid for by insurance. And the ultimate utility in doing routine whole body MRI in everybody is not yet fully established. That being said, the European guidelines currently recommend whole body MRI for everyone in adolescence, young adulthood. Because at that age, you should be able to see the vast majority of plexiform neurofibromas, and it may inform your decisions about additional imaging if there are tumors that are concerning for the potential for malignant transformation or organ involvement. I think probably in the US, we will move to some similar recommendation, but we're not there yet. I do think it sometimes adds anxiety, so I don't recommend it for everybody because I don't feel like it necessarily changes what we do often. And in terms of, sorry, what was part two?
When you would do focal imaging for
plexes.
For visceral plexes.
I really only image plexes if I'm thinking about treating them, to be honest. I don't do baseline necessarily. If it becomes symptomatic, if symptoms are changing, I'll do an MRI at that point, or if I'm really thinking about intervention, either medical or surgical.
Do the T2 hyperintense lesions ever enhance temporarily, or is enhancement pretty generally a cause of concern for malignancy?
In the brain, I assume we're talking about. So for in brain MRI, T2 hyperintensities are seen in the majority of kids with NF1. If they have enhancement or they have mass effect, then we don't classify them as just T2 hyperintensities anymore. We call them presumably low-grade gliomas, but some of those low-grade gliomas do disappear and resolve on their own. So it's almost an unanswerable question about whether or not they are just T2 hyperintensities, FASI, UBOs, whatever you want to call them, versus low-grade gliomas, because hopefully we're just leaving them in place and don't ever look.
For body plexies, do you ever use contrast?
For body plexies, for me, the most important sequences are STIR images, which give a really nice detailed view of neurofibromas, plexiform neurofibromas, but we do get contrast routinely as well.
Okay, quickly, let's move on to Mark. At 13 years of age, he is diagnosed with a plexy in the left carotid space. No pain, no issues. He continues supportive care and observation. Repeat imaging at the NF1 clinic now shows very slow increase in size over subsequent years, and he's starting to develop some cutaneous neurofibromas. It says new dermal plexiform neurofibromas. Those can also appear over age. At 16 years of age, he does start to develop pain in his neck. Here's another question for the audience. If you wouldn't mind voting, what would you recommend? So most would recommend a multidisciplinary tumor board. I would like to also say that as a site of an NF Clinical Center of Excellence, my site and many others are open to regional physicians submitting cases. So you can always reach out to whatever NF Center of Excellence is near you and ask if that's an opportunity if you don't have your own NF multidisciplinary tumor board. And then systemic therapy was also recommended, and that would be an option. We may do additional workup, but he definitely would qualify for systemic therapy if that was the ultimate recommendation. So the MRI does demonstrate that complete resection is not possible for him, given the location. Surgical consult is placed, and instead of pursuing surgery, the recommendation is made that he will pursue systemic therapy. Given this recommendation, I will hand the pointer over to Dr. Chow, who will talk to us about some of the science behind MEK inhibitors and targeted medical therapy.
Thank you. So as was mentioned previously, NF1 plexiform neurofibromas arise because of activation of the receptor tyrosine kinase, RAS, ERK pathway activation, which is seen by virtue of the inactivation of the NF1 protein in this condition. There's multiple sort of nodes along this pathway that are amenable to pharmacologic targeting because many of these nodes, including the receptor tyrosine kinase and all of these intermediates here, are kinases which are ultimately pharmacologically targetable and inhibitable. So MEK inhibition was quickly singled out as an important node in this pathway where very potent and specific drugs were able to be developed. So as a result, a couple of landmark clinical trials, which we're going to discuss, have resulted in now a couple of these MEK inhibitors being FDA approved for use in NF1 plexiform neurofibromas. Selumetinib was the first FDA-approved drug for plexiform neurofibromas. In April of 2020, it was approved for patients 2 years of age, pediatric patients 2 years of age and older. And then this was subsequently expanded in September of this year to include pediatric patients a year of age and older. And in addition, a new sprinkle formulation of the medication was made available for patients who are unable to swallow capsules. Also earlier this year, I think it was February of 2025, a second MEK inhibitor, mirdametinib, was FDA approved for patients 2 years of age or older with NF1 who have symptomatic plexiform neurofibromas who are not amenable to complete resection. So as we're going to discuss, the approval of these drugs was based on the demonstration in these landmark clinical trials that these drugs are able to result in tumor regression as measured by 3D volumetric analysis. And then perhaps more importantly, especially for the quality of life of this patient population, improvements in patient-reported outcomes and functional outcomes were also seen in the clinical trials. Other MEK inhibitors have also been studied in patients with plexiform neurofibromas, as well as cabozantinib, which is a multi-receptor tyrosine kinase inhibitor. But these drugs have not been FDA approved for the use in this condition, and so we will not focus on them in this presentation today. So as seen in this bar graph, we can see the rate of partial response to different MEK inhibitors mentioned in the previous slide. The two registration studies, the SPRINT trial and the RENEW trial on the right-hand side, reported partial response as defined by greater than or equal to a 20% reduction in the volume of the tumor lesion as measured by MRI assessment. It's important to keep in mind as we kind of look at these results that these were not head-to-head clinical trials, and there was a lot of variables in between these different studies that were quite different. So we can't really compare the rates of response between these clinical trials, but I think it's fair to say that more than half of patients will see a response in their regression in their tumor volume. And that kind of the ballpark response rate between these different MEK inhibitors is pretty similar between them. I'm not sure if there will ever be a head-to-head study that will be done to kind of definitively answer if there's a superiority between one of these MEK inhibitors or another, but that would be the only way to kind of drill down on whether these numbers, these differences that we see here are significant. The time to response was variable between these different studies, ranging from 5 to 12 cycles, and the time to maximal response was also a little bit variable between 15 to 20 cycles. The median duration of response and the median progression-free survival in these two registration studies was not reached at the time of the initial reports of these studies. So now I'd like to kind of drill down on the two landmark studies and just go through some of the data that led to approval of these medications. The SPRINT trial was a phase 2 open label trial that enrolled patients from age 2 to 18 with NF1 associated inoperable plexiform neurofibromas. The patients had to have no evidence of MPNSTs, optic pathway gliomas, or other malignant tumors that would require chemotherapy or radiation therapy. The baseline characteristics of the patients and the disease characteristics are listed here, and I just want to point out, because this will come back in our discussion, that pain was present in 52% of the patient population at baseline. Selumetinib was dosed at 25 milligrams per meter squared twice daily and given continuously, and each cycle was 28 days in duration. The initial report of the SPRINT trial set a data cutoff period of 2 years, and treatment was stopped if there was unacceptable toxicity or tumor progression that was defined as a 20% increase in the volumetric analysis of the target lesion. Primary outcome for the SPRINT trial was partial response, which was confirmed on at least 2 consecutive MRI scans. And they did also report on durable responses that was defined as greater than 12 cycles of response. Secondary endpoints included duration of response, safety, and patient and observer-reported outcomes. So what did this trial find? First of all, there were, in 2023, the trial group did provide an updated report giving the 5-year data cutoff, 5-year treatment data cutoff. And so all of the data that I'm going to present is from the 5-year data cutoff. The cohort of patients was 74 patients, which included 50 patients that were on the phase 2 part of the trial, and the rest of the patients were from the phase 1 part of the trial, but had been given the phase 2 dosing. So at the time of this data cutoff, the mean duration, the mean number of cycles that patients had received was 57.5 cycles. And importantly, like 31 of the 74 patients remained on treatment at the time of data cutoff. The partial response rate was reported as 70%, and a durable response, that is at least 12 cycles of response, was 59%. Okay. Time to response was roughly 8 cycles, and best response, the maximal response was achieved at about 18 cycles, with a pretty wide range there. In this 5-year cutoff, they did actually achieve a median progression-free survival that they could report. So that was found to be 6.7 years or 88 cycles. And then really importantly, at 60 cycles, there's a 61% chance of patients continuing to have a response at that time. The figure on the right-hand side just shows a Kaplan-Meier graph of progression-free survival with selumetinib treatment. Oh, yes. So I was just asked to mention that the selumetinib is an orally given drug. I thought that was kind of, and the cycle length. I think I mentioned that the cycle length was 28 days. Yes, 28 days. Right, so this is a Kaplan-Meier curve, and the blue is the progression-free survival of patients on selumetinib, and this is compared to, in the black curve, a natural history study that was available in the literature. All right, so quickly, adverse events that were reported on the study. You can see that most patients did have an adverse event. However, in the parentheses, whoops, I don't know if I can go back here. I can go back. There we go. In the parentheses, these are the grade 3 and 4 adverse events, which are relatively uncommon overall. So you can see here that gastrointestinal side effects, which were seen by many patients, but they were mostly, I would say, at low grade. I think that an important comment here is on the skin and subcutaneous side effects. Almost all patients had some kind of a rash, and the rashes were variable from erythematous dermatitises to just dry skin. But the acneiform rashes were particularly troublesome, especially in patients that were 10 years and older. Paronychia is just worth a little comment because in some cases this did require dose interruption or dose reduction, and there was one patient that discontinued treatment because of paronychias. And then just a note here on the right-hand side, we see other toxicities that were noted in this trial. The elevation in creatine phosphokinases, even if it was grade 3 or 4, was not clinically significant. It did not require any dose interruption. And then just a comment on the pyrexia that was seen. If you're familiar with other MEK inhibitors, this is sometimes problematic. In this particular trial, there were no patients that required delays in treatment because of their pyrexia. So overall, 8 patients out of the 74 discontinued treatment due to one of these adverse events. Now, MEK inhibitors have been in use for many years, especially in the adult population, and this class of drugs has been found to be rarely associated with retinopathy. We already mentioned retinal vein occlusion, as well as with decreased cardiac function. So these specific adverse events were paid attention to in particular. As you can see, no patients on this SPRINT trial had grade 4 ocular side effects, and the one patient who had retinopathy that was noted, this had resolved by the time they had their next ophthalmology evaluation. Some patients did experience decreased left ventricular function, only one of which was grade 3 in nature. 2 patients had their selumetinib paused during the trial, and this ejection fraction then improved. So they had dose reduction, and none of the patients came off of the study because of decreased cardiac function. So this is taken together. These are the warnings and the precautions for selumetinib that are included in the packaging insert. I will say that because of the concern for cardiac function and retinopathy, all of us do recommend monitoring by an ophthalmologist for retinopathy, and echocardiography, the schedule of which is variable depending on the practitioner, but some echocardiography is recommended to monitor for cardiac function. More importantly, though, we all discuss with families and provide some anticipatory guidance on the on rashes and preventative treatments that can be given, especially in the teenage population, where acneiform rashes can be quite devastating at that time for the patient. On the right-hand side, we just see some of the reported side effects that have occurred in the adult population who have been treated with selumetinib for a variety of different cancer indications. This is off-label use, just for your information. All right. And then, as was previously mentioned, pain is a common symptom of the plexiform neurofibromas, was present in 52% once again at baseline for this patient population in the SPRINT trial. And this was followed, and at both at the year mark and at the 4-year mark, there was a statistically significant reduction in patient-reported pain score. And interestingly, even in patients who didn't reach this time point in treatment, many patients, many of the pain scores also were improved in that population, who may not have had may not have stayed on trial because of other factors. In fact, I think in all of our experiences, we've seen that the pain in patients oftentimes improves prior to response, volumetric response in the tumor from these inhibitors. And even in patients who don't experience any volumetric response, we see improvement in their pain. All right, quickly moving on to the second landmark study called the RENEW trial. This was also an open-label phase 2 trial. Mirdametinib was given to children 2 years and older, as well as there was an adult cohort in this trial. We're going to focus mainly on the pediatric cohort, of course. Baseline demographics and tumor characteristics are once again provided here below. Because this particular trial was designed to enroll patients with inoperable or progressive plexiform neurofibromas, as well as symptomatic ones, there was a higher incidence of pain in this one compared to the SPRINT trial. So 70% you can see of kids did present with pain. Mirdametinib was delivered as 2 milligrams per meter squared twice daily by mouth. And the maximum dose was capped at 4 milligrams BID. The treatment schema here was a 3-week on treatment, 1 week off schedule for each 28-day cycle. And once again, the study was designed to call for 24 cycles or 2 years of treatment, although patients were allowed to continue treatment afterwards on a long-term follow-up study. The primary endpoint, once again, was partial response defined volumetrically, and secondary endpoints included the duration of response, safety, and quality of life and physical functioning reports. So this is a waterfall plot showing the best response of each individual patient's target plexiform neurofibroma. The dotted line above here indicates 20% increase in a volumetric response, which would be considered a progressive disease. And the dotted line on the bottom is 20% decrease in the volumetric response. The objective response rate for mirdametinib was 52%. that met the criteria for a volumetric response, and 76% of these responses were durable, lasting more than 12 months of time. The median time to response was 8 months, and the maximal response the median time to maximal response was achieved at about 13.4 months. At the time of the data cutoff, the median duration of response and progression-free survival had yet to be achieved, but that data surely will come with follow-up of this patient population. All right, so the adverse events are presented here, and they're very similar to what we just discussed with selumetinib. Once again, many patients did experience some form of side effects, but grade 3 and 4 side effects were relatively rare. There were no patients who had retinopathy or cardiac function decreases that required dose pauses or dose adjustments. And overall, there were 5 patients that discontinued treatments out of the 56 on this arm of treatment. Okay, the warnings and precautions are presented here, and it's very similar. I will just note that for both of these drugs, we should counsel patients who are of childbearing age about the possibility for embryo-fetal toxicity. And then on the right-hand side are the toxicities seen in the adult population based on the adult arm of the trial. And then most importantly, pain was reported in this trial, and as you can see, from 3 months on, there was a statistically significant improvement in patient-reported pain, just as we discussed previously. Quality of life was also reported using the scale, and this was a little bit more variable, and there were some differences between patient-reported and parent proxy-reported quality of life, but certainly a trend towards improvement. I'm going to fly over this really quickly. I just wanted to say that there have been trials looking at both selumetinib and mirdametinib, as mentioned, in the adult population, and these drugs were also found to be effective in adults, although the rate of response was maybe a little bit lower than in the pediatric population. And it should just be noted that while mirdametinib is FDA approved for use in the adult population based on the RENEW trial, selumetinib has yet to receive FDA approval for use in the adult population.
We're somewhat short on time. There was a quick question I was hoping you could answer, Dr. Chow. Yeah. Was any subclass analysis done to determine differences between responders versus non-responders in either of those landmark trials that you discussed?
I think I'm trying to understand the question. Is it based on, are we asking about?
The approximately 50% of patients who did not see a change in their tumor.
Right. So the majority of those patients still had responses at the clinical level. So their clinical symptoms, if they presented with pain or dysfunction, did see some improvement. And so that was oftentimes a reason for these patients to continue treatment, because most of the patients did continue treatment. There were only, as you saw in the waterfall plot, there were very few patients that actually saw progression of disease. So they only had to come off study when they had like greater than 20% disease progression. So many of the patients stayed on trial even if their disease did not meet partial response. It should be, you can see from the waterfall plot that even if you had stable disease, you were allowed to stay on study.
Okay. But we don't have, to be clear, we don't have good biomarkers for which patients a priori are more or less likely to respond?
Right. I'm not aware of any biomarkers that are available to predict which patients will respond.
And just to point out that we do not know if a patient is on one MEK inhibitor and they do not respond. If we switch them to another MEK inhibitor, will they have a better response? We do not know. We also do not know if they have side effects that are intolerable on one MEK inhibitor, whether they would or would not have those same side effects on a different MEK inhibitor. We're going to skip this last video because of time. I think I can just move through it. Okay. So this, I'm going to hand it back to Dr. Yohei for the last couple of minutes. And I'm trying to, if I didn't get to your questions for everybody, I'm trying to respond directly, but we have 3 questions left. Maybe we can very quickly go through those at the end.
I will be super quick for this next part then, because I think we should get to the questions. But just briefly, in terms of monitoring, we generally see patients fairly frequently up front, and then we space it out over time. I typically see patients back after 1 month, and then every 3 months for a year, and then every 6 months in terms of follow-up. There's some variation from clinic to clinic about that, but we can talk more about that if anyone has questions about details. And then lastly, we were going to talk about transition from pediatric to adult care. And I will just say a couple of words about that. One is that this is becoming a bigger and bigger issue in many neurologic conditions, and NF is no exception. These patients often don't have a clear path to care during adulthood because there are fewer adult providers. So often pediatric neurologists or other pediatric providers are providing some of that care later on. But when there is a separate provider that is going to be taking over care, it's really important to establish warm handoffs when possible, direct communication, and to have educational sort of about that transition built in from very early on so that it's not a sudden and abrupt change. So we'll just leave it at that.
Wonderful. I did want to point out that I believe that these slides will be distributed, but CEC Concepts does provide some guidelines to assist in transition of care. I'll say just in my personal experience, this is an area where we most often lose patients, is in the transition from adolescence to adulthood as children become adults and are moving away to college and starting jobs. They have previously had pressure from their parents to follow the guidelines and recommendations and follow up with their NF doctor, and once it becomes their responsibility, we do see a drop in compliance.
Plus, all 20-year-olds think they're invincible. So.
Okay, I'm going to leave this summary slide up, and then we'll get through the remaining questions in 1 minute and 40 seconds. Okay. The top question, my understanding is patients on selumetinib don't have an endpoint with the therapy. Is there a point where you stop treatment? The MEK inhibitors are so far just for plexiform neurofibromas and not cutaneous, ? Who would like to take that?
Well, I can start. The conversation I have with families and patients is that I generally will talk about like doing a minimum of a 2-year treatment period, and then to see how what response looks like. And if the drug is well tolerated at that point, I'll offer to continue medication up to about 5 years. At the 5-year point, we're lacking some information past that, so I'll have another conversation with them about the unknowns and whether or not they want to take a medication holiday, and there's always the opportunity to come back to that medication or to switch to a different one. So 2 and 5 years are my sort of like a rough time points.
Do you stop or do you taper off the medication?
I stop. I don't need. There's no tapering required.
In terms of whether or not they can be used for cutaneous neurofibromas, we don't have enough data yet. There is an ongoing clinical trial for mirdametinib in cutaneous neurofibromas that's being run out of Johns Hopkins, but it is not data that we prospectively collected during the registration trials.
Okay. We only have 10 seconds left. For patients who are thought to have NF1 but actually have Legius syndrome, how does the counseling change?
Yes. How's that?
Perfect. There's no need to continue with genetic testing for Legius syndrome. When a patient is known to have it, they can be advised that their children may show signs of Legius syndrome. It's also autosomal dominant, I believe, but that there's no need for further workup. Okay, there were 2 questions we did not get to. I will try to provide those answers to CEC, polling our 2 expert pediatric neuro-oncologists, and thank you so much for joining us. Thank you to SpringWorks, thank you to CEC, and thank you, audience, for joining us.